Good morning, Dr. Wahab. How are you?
Good morning. Good. How are you?
I'm great, great. I see you've been attending the earlier sessions, and I'm so grateful that you're here. So thanks.
No, thank you.
And I'd like to introduce Dr. Naz Wahab, a wound care specialist and serves as medical director for the Mountain View Wound Care and Hyperbaric Center, the inpatient medical director for Dignity Health Hospitals in Las Vegas, and for Post-Acute Medical Hospital in Las Vegas. Lots. So we're gonna turn it over to you to load up and get your presentation going. So the share screen in the middle, right?
Yeah. Oh, here we go.
There we go. Go full. Perfect. All right. I'll see you in a little bit.
All right. Well, great. Thank you so much, Rich. We're going to talk about the use of continuous topical oxygen therapy in combination with CAMPs, which are the traditional CTPs to treat chronic wounds. I'm a physician out of Las Vegas, Nevada. These are my disclosures. Some of the objectives we really want to talk about. So this therapy has been so amazing, and we really need to understand where to use it, how to use it, and why to use it. So I think the importance of wound bed optimization and the utilization of topical oxygen in that aspect is very important. I think understanding the need for continuous topical oxygen therapy to move towards the proliferative stage, and also actually in that remodeling stage. And I'm going to show you some images that will support that. And then understanding the use of topical oxygen prior to the use of CAMPs to improve the success of those CAMPs in the aspect of wound bed preparation. So some of the goals of our therapy really are to support tissue repair, preventing infection, reducing pain, eliminating devitalized tissue, creating a moist wound healing environment, and really decreasing peri-wound edema. So what we had done was actually did a single center case series and looked at the effectiveness of just a singular treatment with the combination of a CAMP, which traditionally we use just one application of one therapy, but this was actually a combination of two therapies that we were using, not at the same time, but we were using topical oxygen in order to do a wound bed preparation prior to the application of a CAMP. And so we're going to go through some of the cases and see some of the interesting images that I collected. And actually, to my surprise, it was far greater than what I even thought. By the way, I was also part of the initial randomized control studies as well. And I really think that the development of the device has actually improved over the years, and the use and how we're using it in this algorithmic system really actually also created just amazing results. So here's our first case. It's a 57-year-old male. Again, all the same types of thing: hypertension, diabetes, obesity. But this patient had actually had the wound for 22 weeks already, and we could not get it to move. We had tried a variety of different products, and obviously the patient had been evaluated for osteo, any correctable vascular diseases, things like that, and he was all negative for all of those things. But you can see that also, unfortunately and fortunately, his wound was so small that he actually didn't qualify for a CAMP as well. And so we started using it thinking that the wound might actually get larger post-debridement. I wasn't in anticipation of such a great result just with the topical oxygen. But you can see that we cleansed the wound, we applied topical oxygen, and here in week 1, 2, 3, and by 4, we had actually achieved closure just with the topical oxygen, and we didn't even make it to the CTP. So unfortunately and fortunately, we got such great results. But if you can imagine that the patient had that wound for 22 weeks prior, and just utilizing the topical oxygen, we got such amazing results. And of course, all the same things: debridement, offloading, strict diabetic control were were obviously assessed and made sure that we did those things. Now you can see I actually have a near infrared spectroscopy camera. And so we started taking images to evaluate what was happening. And this is an image prior to the application of the topical oxygen. So you can see, just to orient everyone, this is just one view on the left-hand side of just an oxygen, the O2 sat of the skin there. And you can kind of see the dorsum of the foot is rather pale. The obviously, the higher the oxygenation, the redder it is. So the more red it is. And you can see on the dorsum of the foot and even on the plantar surface of the foot, it's really not that oxygenated. And we have about a 78% average in the wound itself. And then after 2 weeks of application of the topical oxygen, you can see, look at the top of the foot, the dorsum of the foot. Now, I did not anticipate this type of a result, but you can see that just with 2 weeks of topical oxygen, we were able to elicit a systemic response. And so I think this is important and a distinction, and something that people, all of us, I think, didn't understand, is that the topical oxygen directly on the wound is actually doing much more and creating a systemic effect, which is probably why it's working. It also, that oxygen gradient that's there is probably recruiting more cellular cell signaling and recruiting cells to the area to complete closure of the wound. So it's a very interesting observation that occurred just incidentally while we were taking these images. Here you can see a next case, an 81-year-old male, also diabetic. He incidentally had a melanoma of his plantar surface. He had a Mohs procedure, but ultimately he was also being treated as a diabetic ulcer. I had already been working on his wound for 12 weeks, and that was not even how long he had had the wound prior to that, but that was just my how long I had been working on it. And it was taking a while, and although that wound appears granular and there's some improvement, in 12 weeks, it was really still very fibrotic, very thick, and difficult to debride. And so I think that's really important, that although to the naked eye it appears that that wound is granular, it's actually not quite as granular as we think, and not as healthy as we actually think. We've been using a variety of topical products, again, and still not much improvement. So we started the topical oxygen here. And you can see here now that the progression of even 4 weeks, we improved significantly. So we did 2 weeks of topical oxygen. And here, I just want to give you note that you can see that I had applied a barrier cream to that peri wound. After the application of topical oxygen, you will see an increase in exudate, a significant increase in exudate. There's actually cellular movement there. There's the wound is becoming a lot less fibrotic. It's becoming softer, easier to debride, more exudative. And so because of that exudate, we actually had to protect that peri wound with the barrier cream, and that's why you see that there. But you can, again, imagine that we're moving this from that chronic inflammatory stage to that proliferative stage, and we're getting movement and cellular movement there, and that is why this is happening. And so those are all good things that are occurring. And in fact, we were getting such great results that nobody actually wanted to move to this CTP or the camp. We all actually wanted to continue with just the topical oxygen, but for the sake of the clinical study that we were doing, we really did need to move forward, especially since our first case, we were unable to move forward because we healed in such a significant amount of time. So we started the CTP here. You can see in this image at week 2, and then we continued CTPs. Now, I think, again, retrospectively, the patient got so excited, we got so excited that although I was he was wearing an offloading shoe to the office, and he was telling me he was doing it and giving me all the excuses. I think he did not utilize it as much, and he also was walking way more than he was telling us. And so I do think that that was part of the reason why this may have taken a little bit longer with a little bit more applications of CTP, is because of his compliance issues. But you can see again, we continue to apply the CTP throughout the weeks, and there was continued contracture of the wound. And you can see, you know, by week 8, which again, we had already been working on the wound for 12 weeks prior, and we had never made such improvement. So in 8 weeks, we really made some significant strides. And then finally at week 10, we actually had pretty much complete epithelialization there. So let's look at the near-infrared spectroscopy on this gentleman, and you can see that this was in the midst of the CTP therapy that I took this image. And this was, you could say, about 80% epithelialized, maybe even more, just on this image right here, the raw image here to the naked eye. And then you can see on the left here where the oxygenation is, it is a bit confluent. The oxygenation is definitely a little bit more concentrated here, but confluent throughout the foot in general. Kind of deceiving, because then when you actually look at the image to the right, and let me just orient everyone slightly, is that the top left corner is the oxygenation of the tissue. The top right corner is the deoxygenated hemoglobin. The bottom left is total hemoglobin, and the bottom right is oxygenated hemoglobin, so the oxyhemoglobin. So you can see that it's quite interesting that despite to the naked eye, it appears that it's about 80%, if not more, epithelialized, the hemoglobin requirements here are still so significant. And then when you look at the actual oxygenation, very concentrated in that wound, in the original wound bed, again, probably creating a differential oxygen gradient there. And understanding that we're probably in the remodeling phase, and that even though we are in the remodeling phase, the cellular and metabolic requirements of the wound are still so high that we have such a significant amount of hemoglobin and oxyhemoglobin to the area. And even that does not relate 100% always just to the oxygenation of the tissue. So there's something happening in the cellular level that we really need to take heed of, and understand that there's also continued increased metabolic demands even in that remodeling stage. So here's another case 3, 43-year-old male, insulin-dependent diabetic, and end-stage renal disease, a diabetic foot wound. And he had this, incidentally, he had a prior wound that we had already been working on. So I remember somebody earlier in Dr. Serena's presentation had asked a question on, does anybody use it for a relatively acute wound? Even though this is a diabetic and we know that they move to a very chronic state very quickly, this was 1 week we had captured it because he was already a patient of ours for another wound. And so we placed the topical oxygen quite quickly within 1 week of the presentation of the wound. So you can see here on the near-infrared spectroscopy, this is on presentation. This is prior to the application of topical oxygen. There's a hyperemic looking area here, very localized to the wound. The rest of the foot is still quite pale as in comparison. Oxygenation requirements have not met, or the metabolic demands have not been met by the body here. And you can kind of see that, and hence why you have this wound. And so it's really remarkable to be able to see these kinds of things here in the near-infrared spectroscopy. Again, looking at this a little bit in more detail, that same image is now broken down into a total hemoglobin and a oxyhemoglobin on the bottom 2 images here. You can see that the body is trying to recruit on that angiosome there on the plantar surface to the wound hemoglobin. Unable to get a huge response here at the wound oxygenation-wise, despite the fact that we're getting a response. And there is definitely a concentration of oxyhemoglobin, very much so at the wound site. Again, indicating that metabolic demand. And then you see here, very quickly, we did 2 applications of topical oxygen for 2 weeks. We started with the CTP, and we were getting a good contracture of the wound bed with those applications of CTP. And here, this is, again, a comparison. This is prior to the application of the continuous oxygen. And this is after 1 week of continuous oxygen. Look at the difference in that systemic response. On that dorsum of the foot, there's definitely an increase in oxygenation there, and definitely a recruitment of hemoglobin as well. Next case, or this actually the same case, he goes on to closure around week 8. Here's the last image at week 7 after 5 application of CTP. Again, indicating that we need to have an algorithmic approach. These are hard to heal wounds anyways. These patients have multiple comorbid conditions. He's end-stage renal disease, and he's on dialysis. These patients are vasculopathic and are very difficult, and so targeting them with this algorithmic approach, I think, is very important. This is actually the same gentleman. This was the other wound that we had been treating prior to seeing the previous wound. But this wound we had been treating for about 6 weeks without oxygen. This was just, he had presented. Despite the fact that you can't see it in this image very well, there was tendon exposed. We had done complete workup on him. He was negative for osteo, any correctable vascular diseases, and with debridement and cleansing. And then we started to apply the topical oxygen. Again, having said that, we had been working on this for 6 weeks. And now you can see 2 applications of the topical oxygen. Look at the image and see the edema here, and see how the edema has actually decreased on week 2 with just 1 application or 2 applications of the topical oxygen, or 2 weeks of the topical oxygen, I should say. And that is really quite remarkable, that there's so much decrease in peri-wound edema. This gentleman obviously has a Charcot foot as well. And decreasing all of that edema is very important in controlling that Charcot as well. Here you can see after the first application, we're really getting some amazing contracture. Second application of the CTP, and we're really moving into that closure. And finally, epithelialization at week 6. Here's the images. Important to take note here. Here's the prior to the application of the topical oxygen. You can see that we did get some sort of a topical response here of oxygen, mainly because we had been working on it also for 6 weeks. And also here you can see that there's a concentration, but look that there is, even though we're towards the end of the CTP therapy, we're at probably 80–90% epithelialization, we still have a high metabolic demand of hemoglobin, and oxyhemoglobin is now going down. And so you can see that this is probably moving through that remodeling phase. Again, understanding that there's a metabolic demand in that remodeling phase. And perhaps we should be thinking about continuing the topical oxygen despite the naked eye appearing that it is closed, that there is still room for that wound to reopen and needs cellular support with topical oxygen. And that probably might lend to utilizing it for post-surgical wounds or things like that. I think that it's just opening the door for us to see things visually in a near infrared that we may not see on the naked eye. Here's another case, 76-year-old male, again, plethora of comorbid conditions, had been working on this for 12 weeks. This also was a Mohs procedure because of a squamous cell, but again, with diabetes, and he had coronary disease, and a pacemaker, venous insufficiency, you name it, he had it. And so despite utilizing aggressive yet conservative wound care therapy for 12 weeks, we had gotten to this point. And now you can see we applied topical oxygen for 2 weeks. Look at the peri-wound skin color, how it's changing, and it's becoming less dark. The edema has been coming down significantly. So you can see as the wound is moving through that proliferative stage and to that remodeling stage, what's happening clinically. And then the wound continues to contract. We have the first application of CTP, the second application of CTP. And then finally, we actually closed at 6 weeks. Now, again, we had been working on this wound for 12 weeks prior, and we got more out of 6 weeks than we did the 12 weeks prior, despite doing all the right things. And so I think that there is just a huge use case in using topical oxygen and the CTP in a succession. I have not used it where we use topical oxygen on top of a CTP as of yet, but again, thoughts on perhaps that might work. Here's the near-infrared image of using it prior to the start of therapy. Again, seeing that there is some kind of a response there. But again, on the near-infrared, what we're seeing is that even though you start with kind of this hyperemic effect in that inflammatory stage, that chronic inflammatory stage, then as we come down and going down to that remodeling stage, our oxygenation is kind of coming back down to whatever that patient's normal is. And so that kind of continuum of care and continuum of what's happening in that wound bed should not be neglected and taken for granted either. And to continue our therapy despite our naked eye thinking that this is actually healed or closed. And here's our last case, 87-year-old male, congestive heart failure, peripheral vascular disease. He had a venous leg ulceration. Although this wound does not appear to be significant, it had been going on for over 3 months. It had been stagnant, and it was just constantly giving us green drainage. It was chronically colonized with Pseudomonas. The granulation tissue quality was very poor. And so we decided to utilize the topical oxygen, again, to kind of disrupt those senescent cells, those senescent bacterial cells, disrupt that biofilm, get that, bacteria moving so we could possibly get it out and treat it and really make movement in that wound. And again, this patient did so well just with the topical oxygen. The wound was actually too small also to qualify for CTPs that we actually didn't get to utilize in the CTP on here. But you can see we used topical oxygen for these 4 weeks. And finally, we did achieve closure at that 5th week. So again, discussion, things that we need to be thinking about is that wound healing should be really approached in a systematic, algorithmic way to optimize the wound bed. Wound bed preparation, we've been talking about for years and years and years, but I think this case series really goes to show that wound bed optimization is really needed. It's needed prior to the application of these very expensive CTPs. We know that the LCDs are coming to try to limit our usage of CTPs. And so I think utilizing this topical oxygen as part of that wound bed algorithm is very important. Discussions on why we think this might be working. Again, continuous topical oxygen changes the natural microbiome. Dr. Schultz will talk about this extensively in our next lecture, but it also helps to disrupt those senescent bacteria and start to have movement in that wound bed. It helps to decrease that wound bed edema by mobilizing some of those bacteria from the peri-wound as well. There's changes in that oxygen gradient in that wound bed, which helps recruit fibroblasts and epithelial cells. It supports the body's natural immune response to phagocytized bacteria. There's metabolic demands of the wound that remain elevated even in that remodeling stage. And so oxygen helps to support that remodeling phase. I think it helps to perhaps even increase tensile strength. I don't know. We need to do some more studies behind that and understand when is the oxygen or metabolic demand actually diminishing in that remodeling stage. And the utilization of continuous topical oxygen is really showing that there's a systemic effect to the limb and not just the wound itself. And so we're probably getting a lot more of a response than people really initially thought. So in conclusion, I really do think that topical methods of using this oxygen might have synergistic effects and improve wound healing, and the results of this study really support that assumption. And really with the limitations of LCDs and LCAs coming and the constraints that we're going to be having accessing certain cellular products, I think utilizing our topical oxygen in that algorithmic approach and as a treatment option is really important across all clinical settings.
Excellent, Dr. Wahab. Excellent, very insightful. I love all of the case studies. I mean, it shows the success. I just have really one question, right? So given all the case studies and everything, would you say that adding topical oxygen therapy to the standard of care in non-healing wounds is long overdue?
Absolutely. Absolutely. I think it's very, very much, we've been using hyperbarics for such a long time, and we had a lot of studies and assumptions of how it's being used systemically, and we really didn't realize that it's actually a lot of a systemic response, even just with the topical oxygen on the wound itself. So I think it's very long overdue.
Awesome. Sonia does have a question. Do you measure plasma hemoglobin in the patients? Is there a correlation or risk of poor healing in people with anemia? Topical oxygen application can bypass a lack of oxygen caused by poor vascular supply?
Yeah, actually, it's really interesting. When you use the near-infrared spectroscopy, you can actually see when you don't get that increase in hemoglobin that there's likely an anemia going on. So I've actually diagnosed anemia and just off of the near-infrared spectroscopy. And so I'm not, especially in this study, I wasn't comparing exactly total hemoglobin in the serum or plasma to the near infrared, but you can actually identify an anemic situation based off of that near infrared. At least I've been able to do that in the past.
That's awesome. Then we got Mohammed. What is the solution for maceration among using the use of natrox or use of continuous oxygen therapy?
Like you saw in one of my cases, I just used a barrier cream. Frequent outer dressing changes are probably needed, especially in the beginning. You'll see there's quite a bit of an exudate coming out, and then it sort of plateaus a little bit. And then at that plateau mark, you don't have to change the dressing quite as frequently, the outer dressing at least. And so those are things that I've utilized just to help with that peri-wound maceration.
Well, we got another one. What vitamin supplementation do you find effective, if any?
There's a variety of micronutrient things that we need. Obviously, I prescribe a lot of different vitamins, macronutrients. I calculate the patient's nutritional caloric demands, but definitely we need, a lot of micronutrients. I don't have a specific brand that I'm going to market or say, but I think that's a whole separate lecture all in its own.
I think it's a whole separate event. I mean, for sure. Thank you so much. We'll see you in the roundtable after Dr. Schultz's presentation next.
Great, thank you.
Dr. Wahab, take care.